Now, I think we have some time, quite a lot of time actually for discussion. So we are now opening the floor to any questions. Please identify yourself and then pose the question. Yeah. You have a question? Okay.
David Miller with Tim Ray Brown Foundation. And I had two questions for Sharon and Janet. As we're going forward towards Durban, and for virology education itself in November, there's going to be a symposium on the human microbiome and HIV in Bethesda. And there's going to be a lot more discussion about microbiome restoration in Durban. There's about 7 or 8 different posters or presentations going on. Where do you see future resource allocation going forward in the major networks like the MHRP or the ACTG start addressing the evisceration of Th17s in the gall tissue? And secondly, do you see the role of any further research in APOBEC 3G as a viral host restrictive factor playing a role in cure? Because we hear about the issues of VIF dimerization and host restrictive factors, but everything stops right before something goes into a phase 1. So I'm wondering where the gap from your perspectives lies there.
There was a few things in the question, so I'll just tackle three of the questions I think that were there. The last was around host restriction factors and cure. I didn't talk about that specifically, but I actually do think they play a role. So for those that are not familiar, host restriction factors are basically proteins inside the cell that either block the virus coming in, block the virus integrating, or block the virus getting out. And there's been an explosion of work in this area. I think there is a role around restriction factors that block the virus getting out. You mentioned APACC 3G, that's more about blocking the virus getting in. I don't think that plays a big role because the reality of the challenge that we have here is that people have latency established early after infection. It persists on treatment and you're stuck with those latently infected cells. You asked a question about the microbiome. That's really studying the bacteria in the gut. A lot of work now on linking the microbiome to immunological outcomes, to treatment responses, to mental health. The applications have been huge. I don't think anyone's really looked at it in the setting of cure, actually. Certainly the amount of immune activation in the gut is important for viral persistence, but I don't think anyone's looked at the microbiome and cure.
Thank you. So you mentioned the MHRP, which is where I work. So we are definitely interested in gut microbiome as well as Th17, and we are doing that. Irene Sariti at NIAID is measuring or assessing microbiome in the acutely infected participants and also in HIV-negative MSM in NITIA study. And we definitely see that the microbiome in Thai MSM are completely different than what have been reported in the US. And also there's a difference between HIV positive and HIV negative. And so we are looking at that in the context of the reservoir size and immune activation and so on. Th17, we also very interested in that because we know that's depleted very early. And so we're looking into certain antibodies that may be given at time of ART initiation to try to limit the CD4 depletion and Th17 depletion in the gut as well.
Thank you. Dr. Boucher, you have a question?
Yeah, I have a question to both Sharon and Jason. So what do you think would be the effect if we cure people on the likelihood of getting reinfected? You think there's any protective effect to be expected, or?
It's an excellent question because at the moment we're trying to allow, as Jinshna said, people to safely stop treatment, remain healthy and not transmit. and which means they still are persistently infected, meaning that they've got virus present. There were a number of early studies done showing that superinfection is possible. We know that if you're infected with one clade and you get superinfected with another clade. So I don't think any of the work is aimed towards against protection with superinfection, which I think is still possible.
So you think we should prioritize approaches for cure that are likely to give a post-cure protective effect over others? Because otherwise we make it in a setting where we cure people, but they may be in the future exposed to new infections, and then would basically imply that we have to give them PrEP, and then the benefit of cure is relatively small because you go from 3 to 2 drugs or 2 to 2.
Yeah, I think those options get more and more complex. All the talk around cure doesn't replace the efficacy of treatment, and I think actually a lot of the desires by the Thai interviewees can be achieved through treatment, meaning that you can block transmission, you can stay healthy, but you've got to take medications daily. So the strategies around ending new infections, wide-scale uptake of treatment, PrEP, etc., are 100% the priority. Cure is a strategy to reduce the burden of lifelong ART globally. That's how I see it. I don't think cure, ending HIV and ending new infections will come from wide-scale uptake of treatment and PrEP. I don't know if you want to say.
But I think that, if you look at hepatitis C, it's the same thing, right? You can get reinfected as well. But I was thinking, though, I know that I don't know if it's true, but your Martin Delaney collaboratory has also CMV vaccine in that.
Yeah.
So something that is like a CMV-based vaccine that has a replicating vector that could generate this ongoing immune surveillance may be able to, I suppose, the monkeys got reinfected and cleared again, so that might be one way that could be possible.
Question there? Yeah.
Ying Rouleau from WHO. I have a question to David Cooper on the PrEP study in New South Wales. You mentioned that you are providing Npep in your PrEP study, if I understood it rightly, in the PrEP study in New South Wales. The question is, how many drugs do you offer for Npep in the PrEP study, and is there still a justification to provide Npep when you have PrEP? What's the strength of the evidence for Npep versus PrEP? Thank you.
Yeah, Ying, that's a good question. It was actually the PROUD study that they gave Npep to. So we're asking the participants in APACC New South Wales to take Truvada daily. I guess there might be some who are not adherent to that, or who forget to take it and then have a risk episode. I think you'd have to, that's standard of care, so I think you'd have to offer those people Npep, and they'd be evaluated on their merits. If they've got a good story of taking, adhering to their daily Truvada, I don't think the clinical assessment would be such to offer Npep, but if they're, for some reason they're on a crystal binge and they've forgotten to take it and they come in with a risk exposure, then I think it's reasonable. Oh, and we give 3 drugs, sorry. Yeah.
Yes, Stephen Lochanini from the Doherty Centre in Melbourne. Professor Lewin, my question to you is, what is known about the proviral DNA that's in the latent state? How different is it from host cell chromatin? And is there any role for any of the viral accessory proteins being a part of that difference or similarity between the proviral DNA and the host cell chromatin?
Usually, if you look at this sequence of the virus, of integrated provirus, and it's intact and similar to unintegrated provirus. So the silencing of the virus is largely related to where the virus integrates. So if it integrates into heterochromatin, so it's more silenced and therefore not going to be transcriptionally active, and the activation state of the cell, which is, Stephen's asking me this question because he's a Hep B virologist, and you're going to hear all about it on Thursday. And the situation with Hep B persistence is very different because it's always, whether it's active replication or persistent virus, it's always in the same hepatocyte. In HIV latency, the key factor is that you've got virus integrated into the chromatin in a resting cell. So you haven't got all the machinery there ready to promote transcription. But integration site still is important, not the sequence of the virus.
And a second question is, how sure is the HIV field that there is no episomal DNA? Because what we've learned from hepatitis B is that there's a whole complex of chromatin proteins that rapidly envelop or rapidly chromatinize any viral DNA coming into the nucleus, which is what HIV would do. So I would envisage a not insignificant population of free episomal HIV DNA. But are you sure that it's all integrated?
No, I didn't mention this at all, but there's definitely unintegrated DNA and integrated DNA. And over time, the unintegrated DNA tends to decay. It doesn't have a long half-life. Whether it contributes to viral rebound, I just don't think we know the answer to that.
Sure.
Yes, please.
Yeah, Jan van Lunsen, Vive Healthcare, London, UK. So this is two questions to the cure researchers. So first question would be, we have heard there's considerable progress being made with regard to the shock part of that latency reversion, but there is still considerable lack of, let's say, good vaccines or whatever immune intervention on the kill side. And I would like you to give your guess what would be the most likely, let's say, vaccine out there. We have heard about CTLs, how important they are. You have talked about broadly neutralizing antibodies, and perhaps we have even to combine all of these. And what is the consequence from the regulatory perspective? That would be the first question. Maybe I'll leave it here for the moment. It's a lot of things.
Oh, regulatory nightmare, I would say. But that's what we need, I think, to use combination intervention, which probably will come from different companies and different funders. There are several vaccines that are being looked at, dendritic cell vaccines. All of these, we learn a lot from the cancer field. For dendritic cell vaccines have been used in cancer successfully, so that is being studied. And we are also studying Ad26-MVA vaccine that shows promising results in monkeys. And there are also engineered T cells. Many have been used successfully in chemo-resistant cancer that are now being looked at for HIV. Antibodies, there's so many being developed now, and I think it's clear that we need more than one antibody, and so which combinations would be better is what is being studied as well. But it is very complicated to go, and controversial. I personally think that if we keep doing single intervention trials, we will be at this for decades, and we would not get anywhere. But there also are more risks associated with starting to combine things together. And so I think using animal models to help tease that out would be helpful. But it is, the whole clinical investigation of cure is still much higher risk than just taking ART daily. But as you see from people living with HIV, people have hope and they do want to see a cure in the future. And I think, how do we tread this carefully but also make progress is also very difficult.
This is about David's mention about 90-90-90. It's a very catchy slogan given by UNAIDS. And possibly because of countries like India, which could provide ART at 1% of international cost. However, Australia is achieving 90-90-90-90. It's a cash-rich country with a lot of very less population. India produces one Australia each year. If you look at the calculation 90-90-90, it is 72% achievement, 90% of 90% of 90%. But when we try to calculate the whole world, particularly developing world, is at 60-60-60, which is hardly 20% of achievement. So gap is too much, and the time remaining is only 4 years. So I think it is not achievable by 2020.
Yes.
I think you're absolutely right. There's no question that it's not achievable by 2020. I think the whole, what WHO UNAIDS is doing, I think is what we regard as aspirational. I mean, when I remember 3x5 being launched in 2005, I was absolutely stunned, right? I thought, people are crazy. Is this going to happen? You know, and I just didn't believe it. And it actually happened. It wasn't quite 3x5, but it got very close. And I think these sort of goals that UNAIDS sets and tells the rest of the world, you know, through the World AIDS conferences and World AIDS Day and all of those sort of things, really keep the donors on their toes and keep them honest and keep them, you know, continuing to give the funds. And I think that's important. What we have to do, and Encore was just a little example of that, of reducing costs, right? But what we have to do is, I think, show the donors that there are better ways of rolling out than what we're doing right now, right? So, you know, the classic doctor-patient relationship in antiretroviral therapy is just not going to work for millions and millions of people. And we have to develop faster and smarter ways of getting drugs to people and getting people to take drugs. I think that the START study is absolutely wonderful, because that's the end of CD4 cell counts, right? Someone has an HIV test and you put them on treatment. Don't need a CD4 cell count, you know, unless they're symptomatic, and you might want to consider prophylaxis. But if they're symptomatic, you probably put them on prophylaxis anyway. So I think this is a revolution. Imagine how much money would be saved by just not doing CD4 cell counts. And I think these things, we have to show the donors that we're serious about using their funds responsibly.
There's a question. Yeah, please.
Bob Grant from San Francisco. Congratulations on a series of excellent talks. I was most impressed, though, by the movie of people living with HIV and what motivates their interest in cure research. And what I heard several say is that they want some alternative to taking a pill or a set of pills every day, and they want some relief from HIV-related stigma. And so my question, and I'm sorry if it's a challenge, but my question is, could a long-acting injectable therapeutic regimen address the first question and concern? And do we really think that a functional cure would mitigate HIV stigma in the absence of a social intervention for stigma?
I think definitely long-acting would help. I think many teenagers that we work with said they would much prefer to do injection even monthly compared to taking ARV daily. I mean, with any drug, it's better to have many options. Not one option is good for everyone. I personally think that cure, even functional cure or HIV remission, would help HIV stigma, because now HIV becomes a disease that is controllable and not a disease that is, dependent on being on antiretroviral all the time. And of course, this means that HIV remission would not be, taking antibody therapy every 3 months. I mean, that's still maintenance therapy, but I do believe that it will help stigma. Maybe not for everyone, but for many people we work with, just knowing that their own body is controlling the disease, and that's a possibility and I mean, for me personally, this is the most important reason why I want to do cure research, is to reduce stigma.
I was quite taken by the video as well, because a lot of the things that people were asking for, I feel that we have available now. Simple treatment, PrEP, and I did also think about the stigma issue, and I'm not so sure cure will address stigma. I do think there's a lot of other things that we need to do, but for me the big advantage around a cure is to tackle this issue of long-term funding of lifelong ART, which obviously on an individual level we didn't hear at all from the participants who were talking about what it means to them personally. But we've got advocacy, we've got aspirational targets, we've got potentially an engaged global funding community, but can that be sustained forever for 37 million people? That's probably the biggest driver for me around why we need an option from long-term antiretroviral therapy.
There's a question at the back.
Just 2 real quick questions and a solution and a suggestion regarding a solution upcoming to Durban. Number 1, we've got 5 of the smartest people in the field on the podium before us. The numbers. How much do we need for the Delaney, for the MHRP to be robustly funded, for the ACTGs and everything else to move forward towards real cure research? What's the number? Because in November, things are going to change. Number 2, what's the number for getting to 9090? What number do we need for PEPFAR? How much money are we going to need? And the second part is a suggestion. At the end of pathogenesis in Vancouver, Dr. Francois Chinozy decided to pronounce that she thought a cure was impossible. It's very likely that any cure that we're going to get is going to have to be developed through industry, through some commercial effort. We've gone from one end of the podium to the other over the past 4 years in regards to HIV cure research. Is there a way to drive consensus so key opinion leaders of international renown don't start making pontifications about whether or not we're going to get a cure going right into Durban with less than 100 days? Because when that happens, it really adversely affects the ability of small biotech companies to raise money to keep their research going, and it really affects and influences the interest of congresspeople who are voting and other legislators who are voting on further funding. So, number 1, the numbers. Number 2, how do we prevent any more premature announcements in Durban?
Well, I think David should answer the question about the dollars. He's been around for a bit longer, and he's also a bit cynical, and I'd like to hear what David says about funding Cure and 90-90-90.
Are you talking about the tension between allocating resources to cure research versus the rollout? Is that... No. Oh, the whole number. Oh, I mean, the numbers. If you look at the contributions of PEPFAR and the Global Fund, I can't remember. It's like 20. What is it? Yeah, 6 billion a year each, isn't it? Yeah, something like that. So it's 12 billion. That's got us to 15 million people. We need to get to 30 million people. I think we can do it more efficiently. So hopefully the replenishment, which the German government decided to hand over to the Canadian government because they've got enough worries of their own right now. So the replenishment will be happening soon. I think it's after Durban probably, but if we get that sort of money, and again I hear what you're saying about the whether a new administration happens in the US. I think if it's a Democrat administration, I suspect PEPFAR funding will be pretty similar. God knows what's going to happen if the other candidate gets in. But but that's the sort of ballpark. I think I have to say, I presume you're a US citizen. I have to say that the leadership that the US government and the NIH demonstrates in this has been extraordinary over the past, the past couple of decades, and I don't think we would have been where we are without that leadership. And I think they do a very good job at the Division of AIDS really does an excellent job at looking at where the best bang for the buck is. And I think one thing we didn't talk about is vaccine, and that does absolutely need to be continued, because that would be the biggest stigma reducing intervention that we could have.
Yes.
I have a question to David regarding the 90-90-90. I think your Australian data show that even getting close to 90-90-90, that you don't have an overall big impact on the number of new infections. So my question is, is it wise to just call out the numbers, or should we also look into the potential to intervene with transmission and infection spreading? So in other words, focus a little bit more on those interventions that actually decrease the number of new infections, and not over-focus on total numbers. And then the question is, how would you do it? For instance, it may very well be that it's the acute infection, it's the 10% of the not identified acute infections that are the source of the epidemic. So you can have 90% detection, 90% treatment, but still not have a major impact.
So it's a really good question, Charles. I think what I'm trying to say is we're very close to 90-90-90, and if you get close to 90-90-90, you'll flatten incidence, but you won't turn it down. And that's particularly in communities that have high numbers of MSM driving the epidemic. So the question is, if you add PrEP into that mix, does that, and keeping the treatment level high, will that turn it over? And that's the hypothesis that we're testing at the moment. It doesn't exclude what you're saying, that maybe you don't have to get to 90-90-90. You could do 70-70-70 or 80-80-80, but have reasonable PrEP implementation, and you may get the same outcome. And I think people are modelling that sort of thing. The last point I want to make is, we've discussed, so the New South Wales Health Department, as have many health departments in, state and city health departments in high-income countries, have put a lot of political capital on getting a lot of people treated. And so for the last 3 years in New South Wales, we've achieved practically 90-90-90. And that's great for those people that we're finding and getting on treatment, but it's not great for the public health thing if we can't turn the incidence down. So I think the question then becomes, if PrEP doesn't work in a high-income universal healthcare setting like New South Wales, Australia, what's the next step? Is it targeting people with acute infection? Is it doing, some of this cluster bustering that was Julia Montana's group reported in the Lancet, HIV, I think, in the last few weeks. I think we need Plan C as well, and I don't know what Plan C is if PrEP doesn't work.
Yes.
This is Professor Dr. Alok Hemal from New Delhi. My question is, nowadays HIV is a chronic treatable disease, just like hypertension, diabetes. There is a gap between developing and developed countries so much. Like in our country, we allow breastfeeding, in developed country, we don't allow breastfeeding in HIV positive mother. Secondly, like for second line treatment, we do viral load, and for first line, even we don't do. We have limited number of drugs, like National AIDS Control Organization, they provide 7-8 drugs in which we give for first line, remaining we give for second line. So my question is that, why don't we provide fund for developing country as well as African country, so we can have global goal for controlling and curing HIV?
Yeah, look, there's multiple questions in there. I don't agree with you about breastfeeding mothers. If you apply the WHO guidelines, then there should be and continuing antiretroviral therapy through pregnancy and breastfeeding, and give the infant prophylaxis, although you probably don't have to. That should eliminate breastfeeding transmission. So I don't quite understand your point on that one. In terms of the costs of first line versus second line, you're absolutely right. I think in any disease, your best outcome is what you do first. And that's the reason I think we need to develop the best regimen for first line and make and cheap and affordable, right? Efavirenz has served us very well, but globally now I think that if you look at the experience in first world countries, the failure rate on integrase inhibitors is extremely low. And maybe that's where we should be moving towards, so we don't have to pay for the expensive second-line drugs.
I want to add, like for breastfeeding, in developing country, pneumonia, diarrhea, other infection, otitis media is more common as compared to HIV. Yeah. So if we don't provide milk, HIV positive mother, then they will get, infection. So death rate is more as compared to without breastfeeding. So that's why we allow, and like some African country, they give single feeding, exclusively breastfeeding strategy. So that we should adopt or not?
I think the I must be. I'm not sure that I'm really understanding, but the WHO recommendation for breastfeeding women is so that if a woman is diagnosed as HIV positive during pregnancy and starts antiretroviral therapy or gets pregnant while on antiretroviral therapy, she should continue that therapy through the breastfeeding period and breastfeed as she would normally, right? And the chance of the baby becoming infected is negligible. So that's the recommendation. And that's called, in WHO speak, is called option B+. And that's what I think we should be following, normative guidance from WHO.